Thank you. And we'll close out the morning with Kim Johnson, who's an associate professor of medicine at Duke University. And then we'll have time for some brief discussion afterwards.
Great. Good afternoon. I was sitting here debating whether I would actually get up and go to the podium. I don't actually think I've ever given a talk sitting here, but I watched Stacy, and she kind of slid to the front, and so I thought that could work for me too. I don't actually have a disclosure slide, but I do have an interesting story to tell slide. So I got in really late last night and had a very long 2 days, and so I'm really exhausted. And so I thought, gee, giving a talk would be really difficult. And I've talked to Rebecca several times and tried to get out of this, but clearly it has not worked. She's persistent. And so I said to one of my colleagues, perhaps you could think of something to do that would get us out of the building, and so I wouldn't have to do the talk. I won't tell you what I suggested. And so when the alarm went off, I said, wow, he actually did it. And when we came back into the building, I said to him, please don't do that again because it's really cold outside. And so the only thing you've caused are cold feet. My feet are freezing. And so I decided to title this The Experience of African Americans with Serious Illness, Shortcomings, and Opportunities. And I really challenged myself to make this very different from the usual scientific presentation that I would give around issues confronting African Americans in end-of-life care. I think, in thinking about the title a couple of days ago, I chose this because I think it's really difficult to think about advanced illness care or health care in general for African Americans without first thinking really hard about what the shortcomings are. But I really wanted to do what Rebecca asked me to do and end on a high note and really highlight some of the opportunities, which, as James will tell you, is not really that easy for me to do, being positive. And so, where do we start? One of the things I asked Rebecca was, what is the story that I should tell? What is it that you'd really like for me to focus on with respect to my research? And she said to me, why is it that you spend your life doing this? Why don't you just tell us about why you chose to study end-of-life care in African Americans and really focused on improving the quality of advanced illness care for this group? And as I thought about that, I thought about probably the first time I was confronted with this question. This is my paternal grandmother. And my paternal grandmother, as did I, grew up in rural Mississippi, a large African-American community. And she's always really stressed the importance of education and been really proud of the education of her grandchildren. And so shortly after I joined the faculty at Duke, I was home and I visited her. It was Christmas vacation. And she said, oh, I'm so glad to see you. And she loves basketball. So she started talking a little bit about basketball. And she said, I'm so proud of what you do. And she said, so what is that exactly again? And so I started talking about my clinical work as a geriatrician, and she was really excited because then she said, oh, this is great because I have a lot of the stuff that you study, and she started telling me about all of her ailments and asking me if I would look at her pill bottles. And then I said, the thing, though, that I'm really getting excited about is the idea of doing some research. And she said, oh, that's really great. What do you study? And I started talking to her about how I study African Americans and hospice use and how people are cared for at the end of life, with really a goal of trying to figure out how we can improve the quality of end-of-life care for African Americans. And she got really quiet. She had been animated and talking, and it's just the two of us. And I waited a few minutes, and I said, the TV was on in the background, and there was really nothing on the TV. She wasn't looking at the TV. And I said, oh, well, what are you thinking? What do you think about that? Do you have any questions about that? And she said, well, no. I think that what occurred to me then as we were sitting there together was there was this elephant in the living room. And finally, she said to me, why would you ever want to study that? She said, well, you grew up here, and so you know that, quote unquote, Black folks have a lot of problems, that we can't get good care for anything we have. And so why wouldn't you be trying to figure out how you could actually keep us from getting the many medical problems we have, or actually making us live longer and getting the right treatment for those things? And so I can't remember what I said. I think I was so caught off guard that I probably didn't have a great answer. And in thinking about preparing this talk, I thought about the time that we talked and what was going on at the time. So this was in probably around 2002, and about a year later, this report came out from the Institute of Medicine, Unequal Treatment, Healthcare in America Isn't the Same for Everyone. And while I'm not sure that my grandmother was ever familiar with the details of this question, the substance of her comment was about the fact that you're focusing on end-of-life care when there is a plethora of evidence to suggest that African Americans receive lower quality care for things that we should be able to do something about. And those things are things related to beginning from the screening from anything like cancer to appropriate treatment of that. And so why is it that you've decided to focus your efforts elsewhere? This is, again, that report and some of the data from it, which just shows that compared to whites, African Americans receive lower quality care across a number of diseases and care settings, and that these differences actually have real consequences, right? They're associated with a greater likelihood of death among African Americans at a given age. And in one study that I found startling, if you looked over a 10-year period, the excess number of deaths among African Americans attributable to lower quality care was nearly 1 million. And so my grandmother had a really great question for me, and probably one that I've asked myself in the many years that followed. I still do this work, so maybe I've come up with an answer that works for me. And so looking back, knowing all the things I know now, having spent a considerable amount of time over the last 15 years thinking about this, why is it that I study this? Rebecca's question, why do I study this? And I would probably say to my grandmother today that it's really about equity. And for me, it's about equity throughout the continuum of illness. Certainly that begins with disease prevention, and we need people studying that. It's about appropriate treatment for whatever we have, and we need people to study that. But for me as a geriatrician, what really speaks to me is the experience of serious illness care. It's the patients I remember, it's the interactions that I value the most, and that we need people who actually work at that end of the spectrum too. And this particular slide is from another IOM report, Crossing the Quality Chasm, and it really identifies these 6 domains of what quality care is. And at the very top of that list is equity. And that's really about making sure that people receive the highest quality care no matter where they are in the continuum of illness, no matter what they look like or what other personal characteristics they may have. And so if I explain that to my grandmother, I would probably say, I agree with you that the men on either side of this equity pyramid should have access to the kind of thing that might keep them from getting lung cancer in the first place, and when they're diagnosed with early stage lung cancer, access to opportunities to pursue surgery and appropriate treatment, but at the same time that we should really be thinking about how we create opportunities for them to have appropriate management of their symptoms, and as their disease progresses, how do we actually ensure that the kind of care they receive is reflective of their goals, values, and beliefs, whatever those are. And so what do we know about the other end of the spectrum? So my grandmother tweaked me about what we knew about that end. What do we know about serious illness care for African Americans? And in fact, the story isn't that different. There are unmet needs from African Americans, no matter where you look in the healthcare continuum, and certainly serious illness and end-of-life care are no exception to that. Compared to whites, African Americans are less likely to have their pain adequately assessed or treated across symptoms for whatever reasons. They're more likely to report difficulties with provider communication and less satisfied with the quality of that communication. And even when the kinds of conversations occur about treatment preferences that we all believe should happen, they're still less likely to get the kind of care that they want. And finally, all of that certainly leads to lower satisfaction with care among African American patients and families. So I have to say, I did allow myself to put in one data slide, but I just couldn't help it. I had finished my talk and it was bothering me. I needed to put in one graph. I tried to keep it simple. And my work has focused primarily on hospice use, and certainly today we're really thinking a lot about how we bring palliative care upstream. But I think many of the lessons that we've learned from that work are applicable to what we're talking about today, number one. And the other thing for African Americans is that the largest amount of data exists for that population, and we haven't started thinking very much about how to move things upstream. And so these are data looking at Medicare decedents and those who used hospice prior to death. And at the very top in the blue are whites, and at the very bottom in the red are blacks. And this starts in the early 2000s and goes on. And so it's a slide that I think I can show because you only need to know two things: that the blue line is higher, meaning these rates are higher for whites with use of hospice services, and that the difference remains pretty constant. And so even though we're all getting better about enrolling in hospice and taking advantage of those services, that the differences continue to persist for African Americans. So before I talk about the barriers, I guess I could talk about why might that be important beyond the fact that we want everybody to use the same services or have access to them. And the big deal with hospice and palliative care services, for all of us, is that it's about improving the quality of care that we receive when we have serious illness and are approaching end-of-life care. We know that those services are beneficial for African Americans too, and as a result, they really have a tremendous potential to actually reduce those black-white differences in the quality of care that we see. We're learning more about the use of palliative care among African Americans, but we don't know what that line looks like yet. We do know that in inpatient settings that these services seem to be equally available and associated with equally positive outcomes. So what are the barriers? What might be the reasons that African Americans use hospice less often? And these certainly might be reasons that they use palliative care services less often. But, I'll provide an argument that's contrary to that, because I think that that's probably not true. And so in some of our own work, we've looked at barriers to hospice use among African Americans. And these are the kinds of things that we've encountered. There are things that have been mentioned by this panel largely, and a lot of the things that Stacy discussed. Certainly knowledge is one. If you don't know about a service, then you really can't use it. We found in our work that lower knowledge of hospice, including just having even heard of hospice among older African Americans, was lower than that for whites. The good news is when you actually had heard about hospice and had some exposure to information, you had more positive attitudes toward the use of hospice and were more likely to use it in the future. And so certainly knowledge is power. Other kinds of things, there's no question that mistrust comes up over and over again, and Stacy mentioned that. I'll get back to some things that Shonda talked about. It's really impossible to think of healthcare outside of the sociocultural context that African Americans find themselves in, and that's about the past. Certainly, we can all point to injustices in medical research in the past. We can point to current disparities in care and the fact that African Americans are quite aware of the fact that they're more likely to receive lower quality care than others. And then, just the thinking beyond what we see in healthcare and sort of what the societal images are for African Americans. There is no question that a mistrust of institutions, in my mind, is quite justified. Other things, spirituality, absolutely important in the African American community, important in many communities, but a huge body of literature to suggest that African Americans more often spend time in church, have spiritual beliefs that are more likely to impact their care, and sometimes, particularly in the case of hospice, those are beliefs about quantity of life over quality of life, beliefs about the potential redemptive value of suffering that inform treatment preferences. And then treatment preferences. So large body of literature indicating that African Americans are more likely to want life-prolonging therapies, even in the face of poor prognosis. But I always remind people that that number still is a minority of African Americans, so a quarter or less, and that the vast majority have beliefs and preferences that are quite consistent with what we're talking about in the room. Yet it doesn't translate into use of these services in that way. And so there's work to be done. When we think about palliative care, what is the work that can be done that might be different? And so I just showed you a slide of barriers. And, I'd like for you to think about whether those barriers are actually addressed by thinking of integrating palliative care earlier in the course of serious illness at the time of diagnosis versus what we've always done. You can get your curative therapy and, oh, now that that doesn't exist, let's get you enrolled in hospice. And I think that the bottom model is more palatable for African Americans because I think knowledge will always exist. But if it's about your treatment preferences or trust or even your spiritual beliefs that are all related to giving up something, we don't ask you to do that, that you actually have the opportunity to not have an either or, but an and with. And so what we do then is respect the fact that there are individual beliefs, preferences, and treatments that actually shouldn't preclude your receiving life-prolonging therapy while you also get therapy that makes you feel better and that helps and supports your families. So what are the best practices and opportunities? There's not a lot out there, and a lot of what I'm going to show you in the next few slides was funded and went away. But I think that the reason I'm showing you is that the guiding principles are important, and they're still the kinds of things we should be aspiring to and creating or recreating might be the right word. And so the first thing is raise awareness. I showed you that knowledge is a huge issue among African Americans, and this is actually an outreach guide specifically for African Americans that's put out by the National Hospice and Palliative Care Organization. On the other side is a flyer actually from the Last Miles Away Home conference that was held in the early 2000s. And I actually attended this pretty early in my research, and for me, it was transformative. There was a large group of interprofessionals, so people from multiple disciplines there to learn really not just about end-of-life care in general, but about those topics that were particularly relevant to African Americans. And shortly after that, I certainly think it galvanized some body of research and certainly raised awareness about this as a different kind of issue in the African American community and promoted a lot of conversation around that. I put in the box in the bottom because I never want to absolve us as providers of actually the difference that we can make with our individual patients and families every day. And that really is about improving communication, listening, and really understanding what people's goals and values are and trying to provide care that's consistent with that, even when it's different from our own. And that can be difficult. What other things are important about raising awareness? And this has been mentioned. Really, Shonda talked a lot about this, and it's really about raising awareness where we live, work, and worship. And I think that there's some really great examples of this for both end-of-life care and what we know about thinking about disease prevention and health promotion in African American communities in general. So on one side there, you see the Harlem Hope Project, or Project Hope, which is really about spreading information about hospice use in the community and normalizing the conversation about death and dying. I think what made my grandmother most uncomfortable is I mentioned the D word, and she really didn't want me talking about that in her house. And on the other side, I just like that picture. Okay, it's not really, President Obama isn't in there talking about hospice use, but the reason that like, why did you put that in there? The reason that I show you that slide is there's been a huge movement to improve health promotion and disease prevention, particularly around managing cardiovascular risk factors like hypertension, hypercholesterolemia, and those have occurred in beauty shops and barber shops. And so really reaching reaching out to communities that are trusted and valued by African Americans. In our own work looking at some of these practices among hospice providers, many hospice providers told us that they go to where the people are and that they try to spread information in places like this. The other thing is the church, and Shonda mentioned this, and I agree, this can be challenging. I do think that our beliefs about serious illness and end-of-life care are so intricately involved in the spiritual that it is definitely a place to go. Within our own church, we have had programs for many years, Go Get Your Way In, that really address that more proximal spectrum of health, and really how do we change the conversation such that we are addressing the full spectrum of health. And so here is an example of a program that started at the Duke Institute on Care at the End of Life, really seeking to educate congregations so that they could then educate congregants about advanced care planning and serious illness care. The other big one really are the partnerships. Let's get a little help from our friends. I think one of the big ways to build trust are really to engage people in the community. When we studied hospices, one of the things that they told us that often worked to increase services to African Americans was to actually make their staff look like the community. And what they meant was that they really were actively involved in trying to hire African Americans at all levels. We understand in healthcare that there are many challenges to that. I think some of the more model programs have thought about, like Stacy's program, how do you engage regular everyday folk who don't work in the healthcare center and in really being a part of the care that we provide. And this is an example of that. This is Laura Hanson's program at UNC. It's called Circles of Care. And what she does is she goes to organizations in the African American community and she assembles care teams. And these are lay people who are trained in really just providing practical support, like getting you to your appointments, information about advanced care planning and hospice. And it's been shown to be quite effective in improving quality of life and just access to the everyday things that you need when you're seriously ill or not. And this is another concept. It's good I'm last because I get to repeat what we've already heard, is that it really does take a village. And someone asked a question earlier about community-based services. The fact is that when you're seriously ill, healthcare is not the only thing you need. And for African Americans who have lower income and fewer resources, those same challenges that they face in getting food, clothing, and shelter are only magnified in the setting of serious illness when someone can no longer work. And so how do you think about providing care that addresses all of those things? Because that's how we're going to improve serious illness care. And so here are two examples. They no longer exist because the funding went away, Balm and Gilead and the Harlem Palliative Care Network. But the common thread is really these partnerships between healthcare institutions, home care providers, community service organizations, and social service organizations. They were successful because they were able to coordinate care over all of the domains that we care about, and certainly faith communities were involved. So, this is my last slide, and I want to talk a bit about two different experiences with serious illness. And I decided to end on this after I talked to my aunt last night. My aunt became quite emotional as we discussed this even many years later. But I think what the story illustrates is that we've come a long way, but there's still a long way to go. And so I already introduced you to my grandmother Johnson, my paternal grandmother. On the other side is my maternal grandmother, Grandmother Bertha. I never actually met her. She died in the 1950s. She grew up in rural Mississippi as well, a small place called Canton, which is outside of Jackson. And what my oldest aunt described, my mother's oldest sister describes, is that she developed some type of cancer. She thought initially stomach, but as she described vaginal bleeding, we decided that maybe it was uterine. She was in her late 30s at the time. And the one thing my aunt said that she remembers most as part of the story is that they were so poor that there were times when her mother wouldn't eat so that they could all eat. There were six children. When she was diagnosed with cancer, she said that she was able to go to New Orleans to the state hospital, not the state hospital, the county. There was a county hospital there. She couldn't remember how long she stayed, but eventually she was transferred back to Mound Bayou, Mississippi. So this is the area where I grew up. Mound Bayou is the oldest and largest historically all-black town in the United States. And eventually my mom with her father and other siblings moved there. The reason she went there is because Mound Bayou had a hospital, Taborian Hospital, staffed by black physicians and nurses. And my aunt remembers that she spent some time there and that there was a Dr. Howard who took care of her. He really wanted to make her better. And she said she thinks Dr. Howard knew he couldn't make her better. And eventually, Grandma Bertha asked if she could just go home. And at the time, my aunt said she knew as the older sibling that it was clear she was coming home to die. But she didn't mention that to her younger siblings, who probably didn't know that. And what she describes, she said it was a difficult time. She can't remember how long they were home, but what she remembers is that there was a lot of bleeding and lots of pain and lots of praying. She said it was one of the most difficult times in their family. What she also remembers is that there was no help, that there were no people who came to the house, that there were no doctors, no nurses, no hospice, that they just did the best that they could. And she ultimately died in her late 30s. My grandmother, Johnson, I have known my entire life and spent many afternoons after school with her eating bologna sandwiches. There was a period of time when I had a bologna sandwich every day after school, and it was waiting for me with the crust removed. And so she lived into her 80s, and she also lived in rural Mississippi, and her experience was a little bit different. 2 years before she died, she developed congestive heart failure, and she had a significant symptom burden. She was in and out of the hospital over that time, more than she was home. She also had a large number of children, fortunately lots of daughters. And so they rotated in and out. She did not want to leave her home, and to make that possible, they had to move in. And they did this in the setting of having their own families, and so they were in and out of her home so that she could stay there. At the time that I mentioned hospice use to my grandmother in 2000, she didn't know what hospice was. And later when she learned, she wasn't that eager about it. Ultimately, in the last 4 months of her life, she actually did enroll in hospice care. And her quality of life during that time was significantly better. You know, what I remember about that time is that grandchildren were in and out of the house, really, doing the work of completion. She wanted to see everybody. It was clear that we certainly all knew where this was going, and I think she did too. Ultimately, she died in the hospital, though, and the reason for that is because she wanted to stay in her home, but she didn't want to die in her home. And so she was transferred to the hospital, where she died peacefully. As I think about these two kind of extreme kind of experiences at the extremes, I think about Grandma Bertha, certainly huge amounts of opportunities for improvement at a time when hospice care wasn't available. And then I think about my own grandmother and how initiation of palliative care at the 2-year mark before death could have meant so much more time doing the things that were important to her at home. And it was certainly great to have those services at the end, but I think she certainly would have had a longer period of time doing the things that were most important to her. And so, I'd like to end with, maybe like Shonda, a call to action. I hope that when we think about the importance of providing equitable care to people, no matter what they look like, where they live, what they have, and what they don't have, and how we develop systems that are flexible enough to do that. And I'll end with this quote from Martin Luther King, which says, of all of the forms of injustice in healthcare is the most shocking and inhumane. Thank you.